Good afternoon, everyone. Thank you for joining us today. My name is Kennedy Swallow. I'm the Health Transformation Communications Manager for HCA, and I will kick off this Healthier Washington quarterly webinar with just a few housekeeping items. First of all, your lines are muted, and they will remain muted for the duration of today's presentation. However, if you have questions at any time, please feel free to use the Q&A function on the GoToMeeting platform. This webinar is being recorded, and we will post the recording on our website in the next week or so, and you'll get a follow-up to that link in the future. Again, I want to thank you all for joining us today. We are going to focus on rural transformation in Washington State. I would like to introduce our panel today. We have Sue Birch, our Director of the Washington State Healthcare Authority, Rachel Quinn, Special Assistant for Health Policy and Programs at HCA, and Gary Swan, Senior Health Policy Analyst at HCA. They're going to be presenting today's Healthier Washington quarterly webinar. With that, I will turn it over to Sue for some opening remarks.
Thank you so much, Kennedy. Thanks, everybody, for joining us. Those of you that I have had the honor and opportunity to meet know that I'm a rural nut. It started, I think, in a recovery mode when I left from Washington, D.C. and came out west and just loved everything about the West. I was so lucky to get a rural clinical preceptorship when I was a nurse and spent 4 months down in Durango, Colorado, and then over time, spent really 2 decades raising my family in Northwest Colorado, very rural frontier area. It was the size of Connecticut with about 50,000 people, and so we oftentimes flew around the state, and I have loved everything about learning about rural Washington, and I have just about gotten to all corners, and Walla Walla, I'm getting down to that part of the state soon. So it's a personal passion of mine, and I really feel strongly that it's also an equity issue, and that we have to really create more uniformity between our rural and urban areas. So we're going to discuss rural, the what and the why of all of this health transformation. Rural hospitals and health systems provide care to over 1 million Washingtonians in parts of the state that would not have access to essential services otherwise. For example, Cascade Medical Center, Diane Blake has call out to you as the CEO over there. They're located in Leavenworth. Rep. Cody and I were so fortunate to walk in there on a Sunday and talk to their staff and meet them. They're the sole provider of health services with a hospital district of 1,200 square miles. And because it's a popular vacation destination, CMC serves the many visitors that come through that area year-round, and it makes it really a critical part of the region's economy. But in Washington State and across the country, these vital services are at risk. In our nation, about 85 rural hospitals have closed since January 2010. And in Washington State, 1 hospital, Walla Walla General, has closed since that time, and others are at risk. Currently, only 9 of the 45 rural hospitals in our state are operating with a healthy margin, which we define of over 5% or more. And 19 of these hospitals are operating in the red. So why are we focusing on rural hospitals, and why are hospitals at higher risk of closure than urban counterparts? Well, there's a lot of things that contribute to this, but there really are 3 main factors, and we're going to talk about these in the next few slides. Things like market factors, hospital factors, and financial factors. So let's delve into this. Rural areas tend to have poorer population health. They have larger aging populations. They have higher unemployment rates. They have less economic diversity, typically, and there's stiffer competition from other hospitals than urban areas. The data shown here shows some of the differences between the rural and urban counties. So rural residents are often older, and they have higher percentages of our communities of colors, especially our Hispanic, American Indian, and Alaska Native populations. They have a greater percentage of rural residents living in poverty with more unemployment and fewer years of formal education. Also, there's a greater number of rural residents that are in poor health or have risk factors like smoking. And I'm proud to say, being part of the gray tsunami, it's hitting our rural communities harder than urban areas. Washington is the 8th most rapidly aging state that comes from our Administration for Community Living's 2016 report. But the good news is, in AARP's most recent long-term services and support scorecard, Washington is ranked #1 for services. And so we really have just a remarkable LTSS system, thanks to our partners over at DSHS. And a shout out to Dee Rector for all of her leadership and base building and that really foundational work. Jefferson County is the 3rd oldest county in Washington with an average age of 56.2, and per capita is the 7th oldest county. So for all others, all but one in Arizona are in Florida, and then we certainly are in this front pack. So there's some additional background information about 1/5 of the population earns $20,000 or less. Half of the population has high school degree or less. Large portions of disability are due to health problems, and large portions of the population experience depression and obesity. So these are things that make rural communities distinctly different. So let's talk a little bit about the hospital factors. Other factors driving closures for the hospitals include how healthcare is structured in rural communities, low occupancy rates, workforce and workforce limitations, and old, deteriorating, expensive facilities. The heart of rural health delivery system, and often the one of the main economic engines in our rural communities, tends to be hospitals or critical access hospitals. We call them CAHs, just so we can kind of keep moving forward quickly. But by definition, these CAHs have less than 25 inpatient beds. And in addition to CAHs, there are rural health clinics and other provider offices which provide primary care to rural communities. Rural health care systems provide essential services for the rural communities, including emergent services, primary care, and long-term care. More often than not, these services are linked to the hospital in different ways, and usually it's a web of services that have evolved out there. Behavioral health services and specialty surgery and services tend to be coordinated with larger, more urban facilities, and sometimes you'll hear about hub and spoke, or how the different conglomerates are creating more integrated systems of care. The more isolated the region, the higher propensity that the CAH own a rural health clinic, and oftentimes the primary care physician will cross staff between the primary care clinic and the emergency department. The emergency department often picks up care gaps or can serve as urgent care for our clients and for the community. And the providers that serve in the rural communities are often responsible for the entire care continuum. This makes recruitment and retention pretty challenging, because things like call coverage, lack of team support, family life, higher levels of responsibility really do drive burnout, and it can be pretty challenging to be out in our rural frontier areas. Over the last decade, data occupancy rates for CAHs show a declining trend. In addition, rural hospitals face provider shortage and workforce recruitment and retention issues. And lastly, some really have challenges with their facilities, where there can be really costly and require funds to update and build towards modern infrastructure. I want to point out that the issues are unique to each rural community, and they are more acute in some areas of the state than others. I've toured around and seen some of the new amenities that have been built, and it is really typical, very much like Medicaid, where we say once you've seen one Medicaid, you've seen one Medicaid. And it's very true for our rural partners as well. Once you see one rural provider, you see one rural provider. And that's why it's really important that solutions continue to be tailored towards local community needs. Now let's talk a little bit about the financial factors. Financial factors are definitely contributing to the rural health system's decline and challenges. Nationally, from 2012 to 2014, rural hospitals averaged a 2% operating margin compared with 5.9% for urban hospitals. So why are there thinner margins? And I mentioned earlier that rural hospitals serve populations that tend to be older and sicker, and therefore they have higher rates of chronic illness and co-occurring conditions than those served by their urban hospitals. Also, about 60% of rural hospitals' revenues are from Medicare, Medicaid, or both, compared with their urban counterparts who are at about 45%. And Medicaid and Medicare payments are lower than commercial payment and reimbursement. Historically, this way of payment helped to keep access in rural communities, but with declining utilization and getting better at reducing readmissions and unnecessary hospitalizations, access to care in many of our rural communities is at risk. So this map shows a health plan mix for hospitals in urban and rural areas, each accountable community of health region. The North Central ACH, which is 100% rural, the light beige in the middle of the state, has 67% Medicare and Medicaid. So again, you might be going, okay, Sue, what does this really mean for our rural providers? And what I'm going to now do is turn this over to Rachel. She's going to walk us through short background on how rural transformation fits into our Healthier Washington construct and our broader transformation efforts. And then Gary's going to discuss our draft blueprint for rural transformation. And before I turn this over to Rachel, I am going to call both of them out to thank them for their pioneering efforts in this area of rural transformation, because they have been spending just an enormous amount of time and energy and really leaning into a really complex challenge. So Rachel, I'm going to turn it over to you, and thank you to both of you for all you've done.
Thank you, Sue, and good afternoon. As Sue described, the current rural health delivery system is not working, it's not sustainable, and it really requires fundamental transformation. As most on this webinar are familiar with Healthier Washington, the Healthier Washington Initiative is at the heart of our state's commitment to provide an equitable, efficient, and effective health system, which statewide, which includes rural communities, which is a big part of our state. And the real goal is broad health system transformation. And we are doing this by, one, redesigning health delivery to support the whole person through an interconnected system. Two, building healthier communities through a collaborative regional approach. And three, improving how we pay for services to make sure we're paying for value, not volume, and ultimately better outcomes. The Healthcare Authority is the largest purchaser of healthcare in Washington State, and so we're lead by example and leading this charge of paying through value through our Medicaid purchasing, our public employee purchasing, and soon to be school employees starting in 2020, which most school employees live in more rural areas of the state than our public employees at this point. So we are trying to use our purchasing power to provide the right incentives to make sure that we're ensuring care focused on the whole person, and that we're the second goal of Healthier Washington, building healthier communities through rural collaboration. We also want to make sure to provide the right incentives to deliver the right care at the right time and the right place, especially in these rural areas where we see rural communities traveling to urban centers, and so we need to ensure that care is being preserved in these rural communities. To achieve the three goals of Healthier Washington, we have a number of transformational core strategies that are needed to succeed. One are the accountable communities of health that are providing clinical community linkages in their various communities, integrating physical and behavioral health care, performance measures, practice transformation support, and health workforce innovation. So here, this slide shows a longer-term vision. Ultimately, we're talking about creating a system that works best for the people it serves and supporting providers and communities so they can change and thrive in a redesigned system. So that is the right side of this diagram. And the current system right now is built on fragmented care, built on volume. There's inconsistent measurements, payments based on volume, and where we want to get is where folks are activated and care is coordinated across the continuum. So what does this mean? In rural communities, this means understanding and working with unique conditions in small communities, isolated areas, because rural communities are different, do not have access to the same health information technology and resources as urban to change their businesses from a volume-based business to a value-based business. I want to emphasize that payment is a tool to drive change in how care is delivered. It's not a means to an end, not an end state. The new payment strategy that Gary is going to outline will incentivize health systems to deliver care differently or transform care. Care transformation is a broad term, but in the simplest sense, we're talking about assessing and continuously improving the way patient care is delivered at all levels in the healthcare system. And in rural communities, we want to think about how do we help these hospitals and health systems focus more on prevention, and how do we help them keep revenue in their various communities. So our Rural Health Transformation Initiative, which Gary will describe, includes testing a new payment approach to drive transformation in partnership with Medicare, because they're the largest payer in these rural communities, to sustain access to care in rural communities and help stabilize rural hospital financial status. And it will also address some of these core foundational supports that are needed in our Healthier Washington initiative, including workforce and integration and performance measurements. Shifting payment is not easy. At times it can be scary, but it's critically important for long-term sustainability of care transformation. I want to call out the Department of Health and the Washington State Hospital Association, who have been working on, with many other partners, have been working on identifying a new payment models that help sustain access in rural communities. They have done fabulous work. The Healthcare Authority has partnered some of this work over the last year or so, and the Hospital Association, DOH, has been working with hospitals, and we believe this model builds on this. It builds into and helps take a more holistic view of care transformation that will build on and sustain on our current transformation work, including our Medicaid transformation work, by focusing on some of the same key areas of behavioral health and opioids, and provide incentives for ACHs to work with these health systems. I'm going to now turn it over to Gary, who's going to take a deeper dive on our transformation model for rural areas.
Thanks, Rachel, and thanks, Sue. So, we've been working with our rural providers for a period of time. We've really leveraged the SIM grant in its last year to accelerate and kick off this work. And we see, under Healthier Washington, we're building sustainability out for other parts of Healthier Washington and ensure that work continues. That's consistent with where we're going with this model. Leveraging the SIM grant through its remaining year to help accelerate and kick this work off, and making sure that we're starting to reach some principled agreements to continue this in 2019 and beyond. So we've been working with our providers, our rural providers, commercial payers, managed care organizations, and of course our rural communities and collaborative associations that operate in this space. And we've circulated a blueprint draft, but we'll be continuing to iterate that over the coming weeks and months. So what we're talking about here, really, at its core, is sustainable access to care in rural communities. Oftentimes, then it's easy to fall into the trap of just talking about sheer financial sustainability of our hospital or of specific sectors within our health delivery system, what we're really talking about is the delivery system as a whole, and making sure that we have that sustainable access in these rural communities. To get us there, there's a lot of supporting pieces that we need to have in place. And we need to support as core to our rural communities, our hospitals in that transformation journey. We're working to support our hospitals through this model to help them focus on the rural health needs of their community. I know that our rural communities are doing a lot of this right now, but we are looking to accelerate that and really build out sustainability under a new type of reimbursement, how we pay for those services so that those investments are actually being rewarded and sustainable over time. Stabilizing the delivery system, so stabilizing our rural providers with a consistent stream of revenue on a monthly basis. Really providing some supports around the opportunity statement for transformation. So looking at your rural delivery system, taking a look at what it is that you currently do in relation to your colleagues that operate, rural colleagues that operate down the road. How can we better tailor our delivery system to meet the needs of that community, and providing you guys, our rural delivery system, some technical support in that planning and implementation. Fundamental to any kind of delivery system transformation is data. So we need to make sure that we are supporting from an epidemiological perspective, a look at the population, where they're going for care, how that care potentially is delivered elsewhere, so that we can create those kinds of interventions earlier in the care continuum, and also to demonstrate the success and viability under new approaches. So making sure that we have the data supports there for folks that take on new models of care. And then really support for the infrastructure. I think that we will talk about this a little bit more in the next couple of slides. We want to leverage all the work that Healthier Washington has laid, in particular the Medicaid Transformation Project, but there are going to be gaps that are needed to be filled for our rural communities, our rural providers. And we'll need to fill those with directed, targeted supports under new types of payment. Additionally, I'd just like to speak a little bit broader in the sense that, operating under a fee-for-service environment or under a volume environment, by virtue of that, to succeed, you have to drive your utilization. Under a model where we're stabilizing revenue and we're focusing on population health, it also creates an environment, more cooperative environment, where potentially we can build out hub and spoke relationships and centers of excellence, rural centers of excellence, that make more sense for the communities that we serve. So I think that there's an opportunity there where we're talking about new types of innovative partnerships with those that are operating currently within the rural delivery system. So sometimes you'll hear this, the blueprint that we released, hear it as a global budget model. But again, what we're really talking about is a different way of thinking about how care can be delivered in our rural communities. And really creating that stable stream of revenue that stabilizes cash flow for our rural providers and allows them to more appropriately focus on health and well-being. Additionally, paired with that, providing flexibility on the right side of the screen, thinking about care transformation, and thinking about care transformation in an entirely different context. Not just about stabilizing from one part of the delivery system to deliver high quality care in another part of the delivery system, but fundamentally rethinking about this in terms of population delivery, provision of care in terms of population health. So moving away from budgeting for individual services or a certain individual service line thinking more holistically around how we provide that care under a fixed amount of funding for a fixed period of time. Typically, we'd be looking at a 1 year of historic look back. While we are looking at higher levels, some consistency around how the budget would be established, or establishing this stable stream of revenue, we need to recognize that one rural provider to the next rural provider is very different. While they may all be critical access hospitals, or most of them critical access hospitals, and they have rural health clinics potentially attached to them, the types of services and what is offered in our one rural community are different compared to the next rural community. So we need to make sure that we are providing flexibility to our hospitals, participating in this model, to allocate those resources where they're most needed. Since all rural communities or rural hospitals are not the same, allowed for that tailored or customized implementation in each rural community. What we are entertaining fundamentally is voluntary, and is something that we're hoping will get strong support from both our commercial payers, managed care organizations, and providers. So, talking about the appropriate cost with the highest quality delivered in our rural communities. I mentioned on this, we don't want to create all new investments in transformation, but rather leverage the ones that we made while addressing any kind of gaps that exist to get us to implementation of a new kind of model. Notably, we're talking about the Medicaid transformation project, under which we're looking at transformation through our accountable communities of health, looking at new resources or new benefits for long-term care, home-based community supports, and then foundational community support, so that the wraparound supports for supportive housing and supportive employment. In addition, making sure that we're aligning with the signals that we sent our managed care organizations through building upon integrated managed care and building upon our goals that we set for value-based purchasing. Core components for transformation, we'd like to underscore as well a couple of key things. Workforce is going to be critical. In addition to those supporting goals that I mentioned earlier, workforce is going to be critical. So supporting new workforce under a new kind of model, working towards the development of care teams, care coordination, behavioral health, and the paraprofessionals that can fill in the gaps on the care team and really meet the needs of our rural community. I think an anecdote that we've heard in some previous forums, as an example, in one rural community, they hired a handyman to go into the home for their rural residents and help make it aging adult accessible to support when the aging family members transfer back into their home community. So workforce is going to be absolutely critical in any kind of new type of innovation or new type of payment model. Aligning with the goals that we set with our accountable communities of health for value-based purchasing. So making sure that we have those aligned incentives. And then again, circling back to health systems IT, making sure that we have those health systems in place. I think we really want to underscore, if we want enduring system change, we cannot do this alone. We've engaged with our rural providers, we've engaged with our managed care organizations, as well as commercial payers. We've also engaged with other providers outside of the hospitals and hospital delivery systems themselves, and engaged with our accountable communities of health. On a state level, we've been working with the Department of Social and Health Services as well as Department of Health, and looking at it from a broader perspective, we all, as a state of Washington, need to be coordinated on this endeavor. But really, kind of key to success is Medicare participation. As I mentioned before, in our earlier in this presentation, Medicare is one of the largest payers, along with Medicaid, in our rural communities. So if we are looking to transform the system and make sure that that is successful, we need to have Medicare participation from the get-go. That will be negotiated through the Center for Medicare and Medicaid Innovation, created under the Affordable Care Act. And they have broad authority for implementation of these types of models. Since 2010, we've seen three such models endorsed, one in Vermont, Maryland, and in Pennsylvania. And we're taking learnings from that engagement through the Center for Medicare and Medicaid Innovation and trying to align with their goals for endorsement of such a model. But really, we need Medicare's buying power, and particularly along the lines of their ability to provide some flexibility and potentially some resourcing to this endeavor to transform from one system to another system, recognizing the fragility of our rural providers. And thus far, through the proposal that we've come up with, we've gotten strong signals that we're aligned directionally with where Medicare is going. But holistically, we all need to be at the table, and we all need to participate in this transformation effort. So this is an aggressive timeline, but I think it's one that sets us up for success. We are leveraging the Healthier Washington State Innovation Model Grant, which expires in January of 2019, to accelerate this work through the coming year. With that, through this period of the fall time, really releasing from an HCA perspective our thoughts and solidifying our thoughts around what a potential new payment model and care transformation would look like, engaging with those interested providers and commercial payers and managed care organizations, and cultivating some support with Medicare, with CMMI, to reach some early agreements in 2019 that will continue this work in the coming year. We have targeted, based off of this initial effort, or this continuing effort, a go live of 2020 for the PIMP methodology. So I think from where we are, we're poised for a lot of success and are working to accelerate this work through the remainder of the SIM grant that moves this work forward in the coming year.
Thank you, Gary. I'm going to address some questions that we've received. One question we've received was, global budget is a new term to me, or I don't know much about it. Have other states implemented global budgets, and what has their experiences been? Gary, do you want to answer that?
Yeah. Global budgets have been around for a while. I think you mentioned a couple of different states that have implemented these kinds of methodologies. At the top of the list is Maryland. I want to denote that they are distinct. They are unique in that they have a different kind of environment for how that their approach is set up. Washington is very much different, and we're working to create a model that makes sense for Washington State. Pennsylvania has implemented a model in a non-rate setting environment, so an environment where there isn't an overseeing body that sets what the rates are for commercial market and for Medicare. For Washington State, for a global budget, essentially what we're talking about is looking a look-back period to what kind of care was delivered and what the cost of that care was delivered to set essentially a budget that will be projected forward in the future. Recognizing that there'd be planned adjustments and unplanned adjustments and all the appropriate safeguards around that to make that workable and a success. And I think one other kind of key piece that we see across all of these models is that there's a governing body. So that there's a body that is a public-private partnership where you have payers as well as providers sitting on the board to really guide the model.
Thanks, Gary. This is Sue. I just want to chime in to what Gary said. We have visited with the partnerships in both Maryland and Pennsylvania, and I just want to share a quote from one of the CEOs that expressed his commitment to this work around having a fixed budget. I believe Eric Lewis was with our work team that went when we all heard from several of the Maryland hospital administrators that they could never imagine going back to the old payment system. It was really reassuring to hear their endorsements of how it has really catapulted them into a culture of health and gave them more secure resources to really drive towards wellness and not just continue kind of in a sick care model. So I just wanted to share that. It was a really powerful statement when he said, I can never imagine going back to the old payment system.
Thank you, Sue. Another question we received that, Sue, you mentioned some hospitals are already in the red. How will that work and how will they succeed under a global budget type arrangement and make sure that they're set up for success? Gary, you want to take it?
Yeah, that's a really good question. I think that this is a question that's been floating around there for a lot of our providers. You know, if a hospital is operating in the red, we want to make sure that we're setting the global budget in a way that lets them succeed economically. And I first want to, before we go further in this, thank our hospital association and Department of Health that has been really doing a lot of great work in this area, thinking about how we can help those folks along and succeed. But really at its core, what we're talking about is creating some stability. So from the care patterns and the care that's delivered in our rural community, you see a lot of variability and decreasing utilization in our rural communities. And this is a way that moves to some stability and focuses on care transformation. So how that care can be provided. With that, we're going to have to pair this with the right kinds of financing and supports that get people, move them from one foot on the dock and one foot on the canoe to being able to fully sit in the canoe and paddle. So we recognize that for those folks that are at the lower end of the spectrum and have those struggling margins, that we're going to have to create the right kinds of pathways and supports that give them enough confidence to step into this kind of model.
Another question that's come up, and I think we hear about a lot, is how can other local providers in rural communities, for example, the FQHCs and primary care docs and the RHCs, be engaged in global budgeting to help hospitals succeed? Gary, you want to take it?
Yeah. So we've been, I think engagement with additional partners is going to be very, very helpful. At a system level, creating the right kinds of incentives and programs to coordinate that care. And I think that is really what we're establishing under a more budgeted type of approach. And I think to Sue's comment from the CEO that they wouldn't look back, it creates those new kinds of partnerships that potentially haven't previously existed in the community, and thinking outside of the four walls of your hospital to really think about population health in a meaningful way. And core partners in that are going to be your primary care partners. So those rural health clinics, whether they're owned by the critical access hospital or they are partnering in your community, and those federally qualified health centers or other rural providers, non-specially designated providers that sit out in your rural health delivery system.
Okay. And Sue, do you have a comment?
Yeah, I just want to add to that. to make Gary's example a little bit clearer, again, we heard about a hospital, rural hospital, that they didn't have a food bank in their community. And so what they did was partner with the community to do a food pantry, and they were also using some of their hospital meal prep services to be part of that activity. So there are times I think we'll see our rural hospitals step up to take a lead role where there are true voids, but I think where they can strengthen existing systems, we want to be part of making sure that that work is harmonized. And when I look at the tools around the improvement plans and the plans from our ACHs and certainly from the hospitals with their community benefit analysis, I think that we can help be a driving force to make sure that we strengthen get necessary gaps and voids in the rural areas.
Another question that came up about kind of data, in that what information do hospitals and states need to make the transition to global budgets, and what support can be provided to rural hospitals?
So as mentioned before, health IT is going to be absolutely critical, making sure that we have the right kind of data infrastructure and support. Part of that is going to make sure that we have multi-payer participation in this data infrastructure, so that when we're talking about population health, we're talking about care transformation and creating some new telemedicine or other kinds of initiatives, that those systems are interoperable, that you're able to have the right kinds of stitched together payer information that allows you to take a look at your health, the health of the people you're serving, and better align those services. I think, Sue, did you have a comment on that as well?
Yeah, I want to just assure folks that we know that we're in an IT environment where we are trying to get crisper with our cost of our services, and also our state continues to be a lead on quality of the services provided. And so through that data aggregation evolution that we are creating, that's the type of information that's going to be better teed up to our rural partners.
Great, thank you, Sue. Another question that I'm getting is, can you say a little bit more about multi-payer engagement and your plans to engage commercial and the Medicaid MCO plans, and what level of plan participation is needed in order for the model to succeed?
Yeah, that's a really good question. We're going to be engaging with our managed care organizations, commercial payers, on this work, in particular over the coming months, to discuss, potential opportunities around this model. From a payer perspective, we think that it's a good learning ground to really be able to focus on the population health and be able to support this rural delivery system. A specific example would be, some of our rural providers, they're cost-based, so if they're making an investment, an infrastructure investment, sometimes our commercial payers or managed care organizations will help to fund a part of that infrastructure investment piece. So it helps us to focus, making sure that we have that alignment across those payers within that community, along with what is really needed for that community for those kinds of infrastructure investments to improve the health and well-being of the people that they serve. And in terms of level of participation for the model to succeed, we're taking a look at some of that, but in the shortest sense, we will need to reach enough critical mass from a provider perspective to make sure that they have enough of their, money in the canoe that they can survive economically if they fundamentally change the way that the care is being delivered. And from a payer perspective, making sure that it's enough of a compelling argument on the payer side that we have that alignment for their participation.
Thank you, Gary. Another question that came in, does the global budget include all critical access hospitals and RHC services? And then how will the global budget interact with the RHC or FQHC encounter rate methodology?
Yeah, those are really good questions. We're looking at how the primary care piece will be folded into the proposed model. Currently, we've been looking at it in terms of the budget itself for those services that are owned by the critical access hospital. But I think we want to recognize, and as we talked earlier, that we need to think a little bit outside the box and think about new types of partnerships in our rural communities. So I think that there are multiple ways that we can get a cut at that to make sure that we're incentivizing those kinds of things. But by and large, we want to make sure that we have those aligned incentives within our primary care entities, whether they're owned by the hospital or not, in that rural community, making sure that those incentives to partner and manage the health population are there. In terms of the regulatory side of things, for the encounter rate provisions from a federal perspective, so making sure that we are following federal provisions, that's going to be an ongoing discussion as we move forward with this implementation. And I think part of that also recognizing that the federal side, from CMI perspective, they have some broad authority to partner with us on if there are some limitations that need to be addressed on that front.
Another question that was asked was, I'm a critical access hospital and I own a nursing home. Would that be included in a global budget methodology?
Yes, currently we're looking at including those nursing home services that are attached to the hospital. And the reason that we're looking at in that context really is that when you're looking at the delivery system, you can't look at it just in terms of isolated, siloed pieces of the delivery. And in terms of operations and in terms of staffing, in terms of how you run your business, that those providing some more potential flexibility in how you do that, but also recognizing that a lot of that is already interwoven and we need to look at it in a holistic sense.
Great. Another question that came up is what support, now that the Healthier Washington SIM grant is winding down, it will wind down the end of January, on the care transformation front, what support will the state provide to assist these hospitals that decide to participate in the global budget so they can succeed under this model?
As I mentioned before, what we're really talking about here is care transformation. So that's going to be fundamental to the model in and of itself. We have kind of financial aspects of this, of what services are coming in, or how we're looking at it in terms of how we're establishing a budget and how all those different pieces work together. But at its core, what we're really talking about is care transformation. So there are some key pieces that will help through the Medicaid transformation project that we will be hoping to leverage and align with. But additionally, we'll be working directly with providers as we develop this model out, especially for those that are interested in adoption of a new kind of model, to think through what does care transformation look like for me and how do I make it work?
Another question that just came in is, will the critical access hospitals bear risk under the global budget model?
Yeah, that's a really good question, and I think is one that's really relevant for our rural providers. We are talking about a global budget, and by virtue of a global budget, we're talking about establishing, based off of some historical look back, a budget going forward in the future. The way that we manage that is through making sure that we have the right kinds of adjustments and the right kinds of tweaks within the model that it makes sense that we're not putting our rural providers participating at undue risk under the model. And in addition to that, safeguards and guardrails put in place, so off-ramp provisions and other provisions that make sense to make sure that if a provider is struggling under this, that they will have the right kinds of safeguards to ensure that we're not putting people out of business. But I think in addition to that, we're also looking at what are all those different pieces that we need to have within the model in terms of resourcing that support that kind of care transformation within the community, and how do we create those new kinds of partnerships and investments that help us to get there.
Great. I still take one last question. 95% of care happens outside of clinics and hospitals. How are you including and incentivizing family caregivers and patients?
Those are really good questions as well. And I think part of that links to the workforce question. So I think core to the transformation effort is thinking through paraprofessionals or the right kinds of support to our providers that gets them right, that in-home support, and really building off of the Medicaid transformation project in that sense.
And I would add to elaborate on what Gary said, building off of initiatives 2 and 3 of the Medicaid transformation project, where we are incentivizing foundational community supports and caregivers for folks to stay in the community, and for family members or other type of caregivers to help out with their care. Since there's no other questions, I think we will wrap up the webinar for today.
Great. Thank you all so much for participating today. As always, we thank you for your time. And if you have any follow-up questions, please feel free to reach out to Sue, Rachel, or Gary. Again, we will be posting the slides and the recording on our website and following up with an email when those are posted. Have a great rest of your day, and thank you all.